Welcome to The Explainer. Today, we are doing a high-yield deep dive into atopic dermatitis. We're breaking down the latest clinical review from Pediatrics in Review and turning it into a focused, practical guide for you, the specialist in the clinic. All right, here's how we're going to tackle this. We've got 3 parts. First, we'll get into the pathophysiology, the why behind the disease. Then, we'll cover the clinical features, the what you see on the skin. And finally, we'll discuss the associations and impact, the what else that affects your patients' lives. First up, the pathophysiology. To really manage atopic dermatitis well, we have to get a solid grip on the fundamental mechanics that are actually driving the disease. At its heart, AD is really a 2-part problem. You've got a breakdown in the skin barrier, and you've got an immune system that's gone haywire. And these aren't separate issues, they are locked in a nasty cycle, each one making the other worse. So, on one side of the coin, you have this faulty barrier. The best way to think of it is like a brick wall. In AD, especially when there are mutations in the filigran gene, or FLG, it's like the mortar between the bricks is missing. This breaks down the whole structure, the skin loses water, and it becomes super easy for irritants and allergens to just walk right in. So what happens when those irritants get through the leaky wall? Well, the immune system completely overreacts. It launches this powerful T helper 2 response. This whole cascade, powered by key cytokines like IL-4 and IL-13, is the engine that drives the inflammation and that relentless, maddening itch that defines AD. And this is where you can see how it all locks together in this vicious cycle. It's brilliant in a terrible way. So, step 1, your barrier is weak, maybe from that FLG deficiency. Irritants get in. Step 2, this triggers that Th2 response. Then, and here's the kicker, those Th2 cytokines, IL-4 and IL-13, not only cause the rash and itch, but they actually feed back and tell the skin to make even less filigran. So the barrier gets even weaker, and around we go. Okay, so we've got the why down. Now let's talk about the what. How does all that complex science actually show up on our patient's skin? And sometimes, how does it fool us? This right here is such a crucial clinical pearl. We have to internalize this. Pruritus, the itch, is the single most universal feature of AD. An itch, even when you can't see a rash, is not some bad habit. It is active eczema, and it absolutely deserves treatment. Now, this is something we absolutely have to get right. How we spot inflammation has to change depending on the patient's skin type. In fair skin, sure, we look for that classic erythema, that redness. But in our patients with skin of color, active inflammation can look very different. It might show up as hyperpigmentation or changes in texture along with the itch. We really have to train our eyes to see beyond just redness, or we risk underdiagnosing and undertreating. And on top of that, AD is a real chameleon. It's a master of disguise. You can have a single patient with several of these looks at once. You'll see the classic scaly dermatitis, of course, but you'll also see lichenification, that thickened, leathery skin from chronic scratching. You can get these coin-shaped nummular plaques, and you'll see follicular eczema with those little bumps around the hair follicles, which again is a presentation you'll see more commonly in skin of color. And it's not just what it looks like, but where it shows up. The distribution changes as kids grow up. In babies, think cheeks and the outside of their arms and legs. Then, as they get a bit older, it moves into those classic flexural areas, the creases of the elbows and knees. By the time they're teens or adults, it often settles on the hands and face. But, a lot of patients don't play by these rules and can have widespread disease. So with all these different faces, this variability, it's easy to see how you could get tripped up. What are the key mimics you need to have on your radar? This table is basically your clinical cheat sheet. It's incredibly high yield. For the little ones, seborrheic dermatitis is a big one to rule out. The key differentiator? It's typically not itchy, and it has that greasy yellowish scale. If you see a really localized rash, you got to think about contact dermatitis. And please, don't confuse nummular eczema for tinea, for ringworm. Nummular eczema is super itchy and doesn't have that central clearing. Okay, for our last section, let's pull the lens all the way back, because AD is so much more than a skin deep problem. To really treat our patients well, we have to understand the whole picture, the triggers, the complications, and the really profound impact it has on quality of life. This is a big one. You're gonna get this question from families all the time. There is so much misinformation out there about diet and AD. But the truth is, the evidence just isn't there to support that food is a common trigger for flares. Pushing for unnecessary elimination diets rarely helps the eczema and can cause real harm, like nutritional problems and a huge hit to quality of life. Beyond the skin, there's a whole host of other issues. That broken barrier we talked about, it's like rolling out the welcome mat for Staphylococcus aureus, so secondary infections are incredibly common. We also have to be on the lookout for eczema herpeticum, which is a real emergency. And then there's the classic atopic march to food allergies, hay fever, and asthma. But it doesn't even stop there. We're now seeing clear links to autoimmune conditions and, really importantly, a much higher risk of psychiatric diseases like depression, anxiety, and ADHD. So when you add all that up, what does this actually feel like for a kid? What is the real-world burden of this disease day in and day out? The numbers here are just staggering. Have a look at this. One large study found that nearly 40%, 4 out of 10, adolescents with AD report being bullied because of it. On average, they miss over 17 school days a year. That is more than 3 full weeks of school lost. It's really no wonder we see that increased risk for depression and anxiety we just talked about. The good news is we don't have to guess how bad it is. We can and we should be measuring this impact. And it's actually really simple. Just incorporate the worst itch numeric reading scale into your visits. All you have to do is ask the patient or parent on a scale of 0 to 10, where 10 is the worst itch imaginable, what was your worst itch in the last 24 hours? That's it. It's one simple number, but it tells you so much about disease impact and helps you track if your treatments are actually working. So, to wrap it all up, here are the 3 big takeaways. 1. AD is a 2-part problem: a broken barrier and a hyperactive immune system. 2. It's a chameleon. Its presentation varies a ton by age, morphology, and especially in skin of color. And 3. The quality of life impact is huge, and we cannot afford to ignore it. And all of this really leads us to the critical question we should be asking ourselves in practice. How do we make that shift in our mindset, from just treating flares as they pop up to achieving true, lasting control? We need to move from being firefighters to fireproofers. And that sets the stage perfectly for our next explainer, where we'll dive into the modern management strategies to help you do just that. Thanks for joining.